over 100 people joining us virtually. Please check the chat for logistics and housekeeping information for the session. Please also note that today's session will be recorded and will be uploaded as a resource on the Columbia Division of Ethics website following the event. This link will be shared with all of you once via email once it's available. Okay, so now for the focus today on the ethics of psychedelic medicine. We are bringing this discussion to our community now because the integration of psychedelic compounds into clinical practice represents one of the most significant shifts in mental health treatment in decades. And these developments raise ethical questions that demand careful consideration. In part, this is because these treatments, some have argued, differ fundamentally from conventional pharmaceutical approaches, often involving profound alterations of consciousness and requiring intensive therapeutic support. Now, we know regulatory bodies like the FDA have begun to evaluate the therapeutic use of substances like psilocybin and MDMA for conditions including treatment-resistant depression and PTSD. And now healthcare providers must grapple, or will soon have to grapple, with complex questions about patient autonomy, informed consent, and the boundaries of medical practice. In addition, it can create pressure on healthcare systems that are now confronting practical challenges around provider training, treatment protocols, and patient screening, all while operating in a landscape where traditional medical ethics frameworks may not fully address the unique aspects of psychedelic-assisted therapy. So in light of the rapid advancements in clinical trials and growing public interest in psychedelic therapy, we feel that this topic is timely, and we're fortunate to have a national expert on the ethical and legal issues related to the use of psychedelics in care. It is my utmost pleasure to introduce today's speaker, Dr. Amy McGuire, who is the Leon Jaworski Professor of Biomedical Ethics and the Director of the Center for Medical Ethics and Health Policy at Baylor College of Medicine. She has a very robust portfolio of NIH-funded research that is focused on the ethical and policy issues related to emerging biotechnologies and innovative therapeutics. She is also the founding director of the Ethical and Legal Implications of Psychedelics in Society, or ELLIPSIS program. She has received numerous teaching awards from the Baylor College of Medicine, has been recognized by the Texas Executive Women as a Woman on the Move. That was back in 2016. She has given TED Talks, the most recent one in 2022, entitled "Can Creating Moments of Meaning Improve Mental Health?" She has served as a member of the National Advisory Council for Human Genome Research and is an advisor to the X Prize in Genomics. She is also currently on the board of the Greenwall Foundation, is a Hastings Center Fellow, and is a member of the scientific advisory boards of Geisinger Research and the Morgridge Institute for Research. Please join me in welcoming Dr. McGuire to Columbia.
Thank you, Sandra, and thank you and Lucas and the rest of you for having me here today. It's a pleasure to be with you all. Let me just make sure I can. My slides moving. There we go. Okay. All right. I'm really excited to be here today to talk to you about this topic. I've got 30 minutes, and I've heard that this is a very diverse audience. So I'm going to do a little bit of level setting and hoping that we can kind of really dig in on some of the ethical issues and more complex issues during the Q&A. But I want to start with just some disclosures. I have done some paid consulting for Lykos Therapeutics in a fairly constrained role with regard to their providing advice around their treatment manual. And importantly, I have for many years worked with Daniel Cooperman and Andy and Path Journeys to organize and facilitate trips to South America, some of which offer participants an opportunity to participate in the ayahuasca ceremonies. So I'm going to be talking about psychedelic use both within and outside of the healthcare setting. And I think it's important to kind of situate my comments in the context of that lived experience. So I want to start with a story. This is the story of Sally, and Sally was generated by ChatGPT, but she very much shares the experience of many people that I have worked with and spoken to, and that have talked about their experience with psychedelic assisted therapy. So Sally has battled major depressive disorder for as long as she could remember. And it wasn't just sadness that she experienced, it was a deep, immobilizing emptiness that no amount of effort or love from those around her seemed to fill. Over the years, she's tried everything: antidepressants, cognitive behavioral therapy, group counseling, mindfulness meditation. Some approaches brought fleeting relief, but nothing really stuck. And her depression was always found its way back into her life, suffocating her sense of self and leaving her to question whether life was worth living. In her late 40s, after hearing about promising clinical studies, Sally came across an article about psilocybin-assisted therapy. She learned that this alternative treatment had shown remarkable results for people with treatment-resistant depression. And though she was skeptical and nervous, she felt like she had nothing to lose at this point. So with the help of her psychiatrist, Sally was able to find a clinical trial for psilocybin-assisted therapy that she was eligible to participate in. She signed up, and her journey began with several preparation sessions designed to educate her and create a safe therapeutic environment. In her first session, her therapist, Dr. Anderson, explained the science behind psilocybin, a compound found in certain species of mushrooms, and how it could disrupt entrenched thought patterns and allow the brain to form new, healthier connections. Dr. Anderson told her, "We're not looking for a quick fix. This is about opening a window to explore your mind in a new way. The real work happens before and after the experience." Over the next few weeks, Sally worked with Dr. Anderson to set intentions for the psilocybin sessions. They explored her feelings of worthlessness, her self-blame, and her disconnection from the world. She was encouraged to write in a journal daily, noting her thoughts, fears, and hopes. Dr. Anderson also coached Sally on what to expect during the psychedelic experience: vivid emotions, potentially difficult visions, and a sense of letting go. Sally practiced mindfulness techniques to help her stay grounded if she encountered these intense emotions. On the day of the psilocybin session, Sally arrived at the clinic feeling nervous but cautiously hopeful. She was led to a cozy, dimly lit room with soft cushions, a warm blanket, and calming music. Dr. Anderson and another therapist, Marcia, would stay with her for the entire session to provide reassurance and guidance. Sally swallowed the psilocybin capsules and laid down on the couch with an eye mask on and headphones. As the effects began to take hold, she felt a tingling sensation in her body and a sense of being transported. The music swirled around her, guiding her inward. At first, she was confronted by a flood of painful memories of rejection, shame, and loneliness from her childhood. It was overwhelming, but Dr. Anderson gently reminded her to breathe and lean into the experience. He said, "These feelings are surfacing, so you can let them go." As Sally surrendered, the emotions began to shift. She saw herself as a young girl sitting alone on a swing. But instead of reliving the pain, she felt a wave of compassion for that version of herself. A maternal, loving voice within her whispered, "You were never broken. You were always enough." Later in the session, Sally experienced a profound sense of interconnectedness. She envisioned herself as part of a vast, shimmering web of life, where every living thing was interconnected by love and energy. She felt awe, joy, and gratitude, emotions that had eluded her for years. In the days following the psilocybin session, Sally met with Dr. Anderson to begin integration therapy. This phase was crucial for turning the insights from her journey into lasting change. Sally described the immense compassion she felt during the session and how it helped her reframe her self-perception. She no longer saw herself as a failure, but as a human being deserving of love and kindness. Dr. Anderson helped Sally explore ways to carry this newfound perspective into her daily life. They developed routines to reinforce the sense of connection Sally had felt, including regular journaling, nature walks, and practicing gratitude. The therapy also helped Sally identify lingering patterns of negative self-talk and replace them with affirmations rooted in her psilocybin experience. Over the next few months, Sally noticed remarkable changes. The crushing weight of her depression began to lift. For the first time in decades, she felt motivated to pursue her passions, painting and volunteering at an animal shelter. Her relationships improved as she became more open and present with loved ones. Though life still presented challenges, Sally no longer felt defined by her depression. She viewed it as a part of her story rather than the entirety of it. The psilocybin therapy had given her a glimpse of what it felt like to live life without the constant shadow of despair, and she worked to nurture that light every day. Sally's journey was not a miracle cure, but it was a turning point, a profound reminder of her capacity to heal and rediscover joy. For the first time in years, she felt genuinely alive. Sounds pretty good, right? So this story, I think, really reflects a lot of people's experience, although not everybody's experience, with psychedelic assisted therapy. And it certainly represents kind of the hope or the promise that we have for how psychedelic medicine can help those who are suffering the most, right? It can help provide relief for the millions of people in the world and in America who are suffering from anxiety, depression, trauma, and more. So I want to talk a little bit about the various components and how we think about sort of psychedelic assisted therapy and access to psychedelics assisted therapy in the United States. But I want to first kind of go back and see where we've come from so that we can see more clearly where we are going. So this is not kind of the first wave of enthusiasm that we've seen around psychedelic assisted therapy in the United States. Many of you are aware of the history of this, but I just kind of want to remind all of us that in the 1950s and 1960s, after LSD was first synthesized and brought to the United States, there was tremendous enthusiasm around the potential therapeutic effects of psychedelic substances. And they're used for a variety of conditions, including mental health disorders, addiction, and other types of medical conditions. However, the use of psychedelics really escaped the clinics at the time and really got integrated into mainstream social movements of the 1960s and got, I would say, tied up in many of those social movements and the political unrest that was associated with them. And in the 1960s, President Nixon declared his war on drugs. And as part of that, psychedelic substances, or many of the psychedelic substances, became Schedule I substances under the U.S. Controlled Substances Act, which essentially made it incredibly difficult to do research on these substances and made it federally illegal to use them. And so we see here sort of decades of a lapse in research or a real sort of downswing in research that was done on psychedelics between the 1970s and the early 2000s. And in the early 2000s, there were some early studies that were done again in psychedelics. One of the first main ones was a study of end-of-life distress using psilocybin that was published in 2008. And it really gave rise to the second wave of interest in how psychedelics can be used for therapeutic purposes. And you can see here reflected sort of this increase in the number of phase 1, 2, and 3 trials that were done. This is on psilocybin, but other substances were being studied as well, starting in the early 2000s, but really through the 2010s and up until the present day. And it's continued to increase, and there's been continued enthusiasm. In 2018, the FDA designated MDMA a breakthrough therapy for post-traumatic stress disorder. And then in 2017, and in 2018, they designated psilocybin breakthrough therapy for severe depression. This fueled the enthusiasm around the potential therapeutic effects of these substances. That, I think, combined with a social interest in psychedelics that we've seen through Michael Pollan's book, How to Change Your Mind, and the popularity of that. It was also made into a Netflix series. There was the Netflix series Fantastic Fungi that talked about the power of mushrooms, the healing power of mushrooms. And then there was lots and lots of sort of social awareness of how psychedelics were being used. So there's news articles that were coming out in the popular press around microdosing magic mushrooms to boost your careers in Silicon Valley, right, and enhance creativity. There was a article that talked about moms microdosing mushrooms to ease the stress of parenting and how people were using psychedelics in these ways that were more mainstream, but to help with a variety of different medical conditions, but also just sort of conditions of life. And this led to what many people have described as a psychedelic hype bubble, which is this idea that perhaps there was a exuberance of enthusiasm that wasn't grounded in the actual data that was being generated or the science behind it. However, the enthusiasm did have some grounding in clinical research, and there have been several smaller but impressive clinical trials that have been published that have sort of fueled this enthusiasm. So in 2023, we had a phase 2 study of psilocybin for depression that USONA published. This was a randomized control trial that they did of 104 participants with major depressive disorder, and they were randomized to receive either 25 milligram dose of psilocybin or 100 milligram dose of niacin placebo, and it was administered with psychological support. And the psilocybin treatment was found to be associated with significantly reduced depression scores compared to niacin from baseline to day 43 and from baseline to day 8. So the idea that it had sort of immediate and a little bit longer lasting effects. Also, a month later, MAPS published their phase 3 trial of MDMA for post-traumatic stress disorder. Again, they randomized 104 participants with PTSD to 3 sessions of MDMA-assisted therapy, psychotherapy, or placebo with therapy. And MDMA was found in this study to be associated with significantly reduced PTSD scores compared with placebo from baseline to 18 weeks. And this phase 3 trial of MDMA really prompted MAPS, which then partnered or got bought by Lykos, or I guess combined with Lykos, Therapeutics, which is a drug company, and Lykos brought MAPS's MDMA compound and its use as a psychedelic-assisted psychotherapy to the FDA as a new drug application for the first time. So this was the first time FDA was now reviewing a new drug application for a psychedelic-assisted therapy. And there was a lot of enthusiasm in the field that FDA was for sure going to approve this medication, and we were going to have MDMA-assisted therapy available through the healthcare system in an FDA-approved manner. It's a long story. There was a advisory committee that met and reviewed all of the data. There was some backlash against some of the ethics related to the trials that were conducted and some of the concerns around it. And ultimately, on August 9th of this year, FDA came out and said that they could not approve the new drug application for MDMA-assisted therapy by Lykos, and that they requested that Lykos do an additional phase 3 study to generate more data that would help them make a decision down the road. So this was a little bit of a crushing blow, I think, to those who were advocates of psychedelic-assisted therapy, and particularly to patient groups that were really hoping that this would be a new treatment. There hasn't been a new treatment developed for PTSD in decades, and this was held out a lot of promise for individuals. But what were the concerns that FDA raised? And there were many of them associated with the trials that were done. So I just want to kind of review a few of these just to see sort of where the thinking is from a policy perspective. So the first one was a concern around functional unblinding. And I love this cartoon by Tim Ferriss that shows, it shows 2 groups, obviously, and this is a psychedelic assisted therapy session and a clinical trial. And it says, so I'm guessing we're in the placebo group among those who are fully dressed on the couch. But it's this idea that it's really difficult to have a blinded study of psychedelic substances. It creates subjective effects in individuals where you kind of know if you're tripping or not, right? And so the idea that it's really difficult to know if you're to do a study where somebody doesn't have expectancy effects associated with knowing if they're on the drug or not can be challenging. Now, I will say I don't think this is unique to psychedelics. I think we have blinding issues in other types of clinical trials as well. Maybe not to this extent, but we do have blinding issues, and it's a problem and can cause challenges for a lot of different clinical trials. And we try to find ways to work around that. The second issue is that Lykos came to the FDA with this MDMA-assisted psychotherapy, and they were adamant that the MDMA compound itself was a tool to enhance the psychotherapeutic process, and that was essential to the outcome. The problem with this is that FDA has jurisdiction to regulate drugs and drug products. They don't have jurisdiction to regulate the practice of medicine or psychotherapy itself. And so this was a big problem for them, and they were having a hard time trying to understand what was the role of the psychotherapy in the effects that they were seeing and what was the role of the drug itself. And they wanted to have more information about trying to tease those things apart. And so that's one of the things that they're looking for in future trials. The third thing that came up was around therapist abuse and the potential for therapist abuse. So this is a image from a video that was taken during a MAPS study in Canada. And it shows the two therapists who were treating an individual. Her name was Megan Buisson. She's come out publicly about her experience. She suffered from trauma and post-traumatic stress. And she eventually, these are her two therapists. You can see them kind of spooning her in bed. Clearly seems like it's a boundary violation. They ended up developing a sexual relationship with her outside of the trial. And there was a lot of news around this, but this raised the question of whether this is, it's never excusable to have these kinds of boundary violations in clinical trials or medical practice under any circumstances, but is it more likely to occur in something like psychedelic assisted therapy, where individuals are particularly vulnerable, they're very suggestible while they're under study drug, and there is the potential for bad actors to behave this way. And this wasn't directly a consideration by FDA, other than for them to think about whether their REMS, their risk evaluation and mitigation strategy, which is what FDA can put out when they approve a new drug, whether that was sufficient to potentially protect against these types of risks. And one of the things that they were proposing in their proposed REMS was having two people in the room at the same time. Obviously, in the situation that wasn't enough, but you can do other things to have sort of harm reduction and safety measures in place. Again, MAPS had video recorded the session. That seems like it should help deter these types of things. It didn't deter it in this case. You can have other sort of things that we can think about that would help with that situation. And then finally, and I think this is kind of probably one of the main considerations for FDA, was that they felt that there was insufficient data on the potential addictive properties of psychedelics and the long-term adverse events. So a lot of the studies that had been done hadn't actually collected long-term adverse event data from all of their participants in a rigorous way, and they wanted more information about that. Okay, so that's where we're at today. FDA has not approved this. We can access psychedelic assisted therapy for patients who need it through clinical trials if they're eligible to participate. But that doesn't mean, I don't think, that people are going to stop seeking out psychedelic assisted therapy in the short term. I think what that means is that people are going to continue to go through alternative pathways to access these drugs. And there are several alternative pathways in the United States. The first is that you can go through what are now state-sanctioned programs. So I want to point out that most psychedelics, so psilocybin, MDMA, and several others, continue to be Schedule I substances under the Controlled Substances Act, which means that it is federally illegal to use them. But there are states that have now decriminalized at the state level particular types of use. So in 2020, Oregon voters passed Measure 109, and this puts in place a psilocybin adult supervision model for people over the age of 21. The way that this works is you don't need a prescription. It is not medical care. But if you're a client, you must complete a preparation session with a licensed facilitator before consuming psilocybin products, and you have to consume them at a licensed service center. So you can't just go home and take them. You have to do it at the center. And the facilitator is there with you while you're taking the substance. It's advertised as a health and wellness option, but I want to point out that facilitators are not licensed healthcare providers. All you have to be a facilitator in Oregon is you have to be 21 or older, have a high school diploma or the equivalent, be a resident of Oregon, complete a facilitator training program that consists of at least 120 hours of instruction, pass an exam, pass a criminal background check, and pay a fee. So those are the facilitators. Colorado passed Proposition 122 in November of 2022. And this allows adults over 21 to grow and consume psilocybin and psilocybin mushrooms and their derivatives, as well as other psychedelics like ibogaine, mescaline, and DMT for personal use. So people can also sell bona fide support services associated with psilocybin, and they can share, but they cannot sell the drug product itself, right? So if you're offering like facilitation services, you can give people the psilocybin, but you can't sell it to them. You can sell your services to them. Okay, so these are state-sanctioned approaches, and in Oregon and Colorado, it's now you're able to access psychedelics or some psychedelics through these mechanisms. There still continues to be, and I would say, an increase in illicit personal use. So you can access psychedelics through anybody you know who's selling it on the black market, and you can participate in that way. And then there's a growing market of medical tourism. So these are individuals who are traveling to other countries where it is legal to use these substances and using them in those settings. One of the problems with both illicit personal use and medical tourism is that it's very difficult to know where to access these things, who to trust, what is a legitimate service. And so people are increasingly turning to organized retreat centers that are offering these services. And you might do a retreat. These retreats can vary significantly. You might do a retreat where you're traveling to Jamaica or Colombia or Brazil or Ecuador and doing a retreat with local people there. Or you might do a retreat in somebody's backyard in upstate New York. So these are being offered to a variety of people in a variety of settings. These retreats have gained a lot of attention. You can see lots of news articles here. People are advertising luxury retreats. What are the best luxury psychedelic retreats you can go on, where you can have sort of this luxury getaway while also enhancing your life and learning more about yourself. However, they're not all safe, and there seems to be a tremendous amount of variability in the retreat industry to the extent that it's a cohesive industry. So these are just two news stories that have come out in the last couple of years. The first one here is of Rebecca, who's from New Zealand, and she claims that she was sexually abused by a shaman in Peru while she was getting treatment from him down there, and that he coerced her into sexual acts. And I think this was particularly troubling because as a shaman, she says in the article, she really saw him as a moral authority and having moral superiority. And so she really trusted him in that way. And we've heard other stories of this as well, of people in South America and other places where there has been abuse. The story on the right is really concerning. This is the story of Brendan Begley. He was a healthy 22-year-old who traveled from South Florida to Orange County for an ayahuasca retreat at the Soul Quest Church. So this was in the United States, and it happened in 2018. At the retreat, he drank ayahuasca and was also given Cambo. And while he was purging from the medicines that he drank, he had a bunch of water. They kept giving him water, and he had too much water, they think, and his sodium levels dropped, and it caused a seizure. And the problem was that the owner of the church, Christopher Young, waited hours to call 911 because they felt like they could handle it within the context of their what they were doing at the retreat. They didn't feel like they needed outside medical attention. Ultimately, Brandon died. And Young was found negligent, and he and his church were ordered to pay a combined $15 million to Brandon Begley's family for wrongful death, and then the church eventually was shut down. So these kinds of stories give us real pause and raise concerns about the potential safety of the entire retreat industry, especially as we see more and more patients looking to these services out of desperation. So I just briefly want to talk about a study that we've done, and I'm going to give very high level information. This is called the TRIP study, and we were looking specifically at organized retreats that are advertising in the United States. We looked at we found 298 retreat organizations that were advertising in English in the United States. And they were located all over the world, many of them in the United States, which means that they're operating sort of in a illegal or fuzzy, from a fuzzy legal perspective. Of the 298 organizations, they offered 648 retreat experiences held in 440 distinct physical locations. 7 of them were online. And about a third of these were in the United States, and the rest were all over the globe, as you can see here. They had lots of variation in their practices. So it was really hard to say there was like one that a retreat looks a certain way, right? So they varied in length from one day, you just come to my house for an afternoon, all the way up to more than 2 weeks. The average cost, depending on length of time that the retreat was, ranged from $368 for the one-day retreats up to an average cost of $3,488 for retreats that were more than 2 weeks. And some of them were outliers and were charging hundreds of thousands of dollars for longer retreats. One charged $500,000. I don't know who's going on that, but and then they offered a variety of different substances. So most of the retreats that we looked at offered either ayahuasca, psilocybin, San Pedro, or some combination of those substances. A few also offered things like ibogaine, bufo, peyote, DMT, MDMA, and LSD, sometimes in conjunction with ayahuasca or psilocybin or San Pedro, and sometimes on their own. Okay, so I really just want to take the last few minutes and look at what is the role of clinician involvement or gatekeeping in these unregulated settings, and that'll help us get to answer this question of are we ready for this as a healthcare provider force? So I want to talk about a couple of things that we found in our study that really, I think, raise questions about how or when healthcare providers either should or need to be involved in these activities. The first is the fact that many people we know are going on these retreats for self-treatment of what are serious medical conditions. They're desperate. They haven't found relief in other conventional therapies, and they're looking for something here. So most of the organizations that we looked at do not hold themselves out as offering medical care or medical services. They hold themselves out as offering wellness services, which means it's for your health, but it's a little more vague than we're providing medical treatment. But we know that, and people are anecdotally saying that they're going to these retreats for the purpose of treating what has been a diagnosed medical condition. The second issue is that there can be participation in these retreats by those for whom psychedelics are contraindicated. So we know that we think psychedelics are contraindicated for people who have a personal history or family history of psychotic disorders. There can be issues associated with cardiovascular risk if you have certain cardiovascular pre-existing conditions. And most organizations that we look at actually screen people. They do a medical screening of people ahead of time, meaning a survey, saying, do you have any of these conditions or a family history of any of these conditions? Most of them ask about mental health conditions as well as cardiovascular, although some of them ask about other conditions as well. The problem with this is that it's all self-report. And individuals who are desperate may either not be truthful in their reporting of this, or they may not know their family history of some of these things. And if there isn't sort of the appropriate emergency protocols in place, you're in the middle of the jungle somewhere in South America and a really bad event occurs and there's no medical personnel on site, it could be quite dangerous. Polysubstance protocols. So this one I think is probably my biggest pet peeve. And what we found is about a quarter of the organizations, of the 298 organizations that we looked at, allowed more than one substance at a single retreat. And what we heard anecdotally when we interviewed retreat participants is that there are many retreats that are offering protocols that look something like this. It's a 3-day retreat. You go, and the first night you do ayahuasca. During that, you wake up, and during the day you do San Pedro, which is a mescaline, like a peyote type of thing. The next night you do ayahuasca, then you do San Pedro, then you do ayahuasca, and you might end with San Pedro, or you might end with the ayahuasca. There is no evidence that that amount and combination of drugs is beneficial in any way, and there's the potential that it could be quite dangerous. And so we need to look at sort of those practices and why they're developing and what's sort of like the story behind why that's necessary and what benefit it's providing, and understand better how we can protect against that. Medication washout is another huge issue. So we interviewed 50 of the retreats to get more information that wasn't available online. And of the 50 retreats that we spoke to, almost all of them required their participants to get off of their SSRIs before participating in the retreat if they were on SSRIs. The amount of time you had to be off your SSRI ranged from 1 day, like just don't take it the day that you're taking the medicine, up to more than 6 weeks in participating in the retreat. There was no consistency. There didn't seem to be any acknowledgement of like, why are you on this SSRI? What medications are you on? Is there more than one medication? And most of them suggested you should talk to your physician to figure out how to get off of your SSRIs, but we don't know if people are doing this on their own, if they're doing it with their physician's help, or what's happening. And that can be quite dangerous for individuals. And then finally, integration and follow-up care. Only about a quarter of the organizations that we looked at offered one-on-one integration sessions during the retreat, and 38% offered one-on-one sessions post-retreat. So people are doing these experiences, and we heard in Sally's story how important it is to do that integration for the efficacy at least, but also for safety, because if you have a negative experience and you have adverse events that occur and persist long-term, and you don't have appropriate follow-up with anybody, it could lead to dangerous outcomes. So are we ready for psychedelic medicine, right? We have sort of this pathway that's happening through the FDA process. It probably will happen in the next few years. We have this unregulated pathway happening outside of the FDA process. I don't think that's ever going to go away. That will continue to exist. Are we ready for it as a healthcare workforce? I would say that I think from the perspective of patients who have endured horrible suffering with no relief, the answer is a resounding yes. They think we are ready for this. They want this. They are desperate for it. From the perspective of our healthcare system, and we can talk more about this, I think the answer is probably maybe. I think we can probably accommodate this in our healthcare system, but we have things that we need to do to be able to get there. But from the perspective of healthcare providers, who are going to have to navigate these treatments with their patients, whether they're provided within the healthcare system or outside, because I contend that healthcare providers are going to have to be involved with their patients, regardless of where they're sourcing this. I think the answer is not yet. We need a lot more education. We need a lot more work to be done. And I just want to point out that I think you guys are leading the way here at Columbia. I'm really proud to be here talking to you. Heidi Allen in the School of Social Work has partnered with folks at Penn in the School of Nursing, and you guys have developed sort of the first ever psychedelic therapy training program for social workers and nurses who are not going to just become psychedelic therapists, but who are going to have to integrate this into their practice with patients in all areas of practice. So I'm going to end there. Just want to acknowledge our wonderful team and our funding by the Ortis Foundation. And I hope we have a robust conversation about some of these issues. Thank you.
Right. Thank you so much, Amy. Your presentation was fabulous, and it raises a lot of really important questions. So I just want to encourage you all in the room to raise your hand if you do have questions. There are microphones that are going around. We have over 150 people in the virtual room, so I know there's expertise in the Zoom room. So please put your questions in the chat. We're not able to acknowledge raised hands. If you could just put it in the chat, that would be great. But I'm going to kick us off, and I'm going to ask you a question, Amy, about an area that you weren't able to get to, but I know that you've been thinking a lot about, and that has to do with the extraction of knowledge, particularly among Indigenous groups, with respect to the use of psychedelics. And as we think about these drugs becoming more mainstreamed, are there certain ethical obligations that we should be thinking about in terms of demonstrating respect, or even going further in terms of the commercialization of some of these interventions with respect to Indigenous peoples?
Yeah, thanks, Sandra. So that is something that I have given a lot of thought to and care a lot about, so I appreciate you asking the question. So I mentioned that the first time I ever worked with an Indigenous group that uses ayahuasca was in 1995. So I've been doing this on and off for a very long time, and I have tremendous respect for the Indigenous communities that have used this knowledge for millennia and use these substances in a variety of different ways, not just for healing purposes, but for ceremonial purposes, for rites of passage, for preparing for war, for all kinds of different things. And I've learned a lot from my friends down in South America who I worked with. That's a huge question. The commercialization piece is a whole question about sort of what kind of benefit sharing and what kind of reparations are owed to those communities. And I don't think we have a whole lot of time to get into that, other than to say I think we need to think really carefully about that. And as we commercialize these things and we're making money off of them, we ought to be thinking about what we need to give back. In terms of our ethical obligations, I will say I've been thinking about this quite a bit lately, because I think that we have these two different sort of systems that are based in really, really different values, right? And we can't forget that. So we live in our world of like Western academic medicine, And we have to kind of step back and say, like, what is our orientation and our worldview that informs how we think about Western academic medicine? Western academic medicine is, for the most part, grounded in sort of Enlightenment era rationality, right? We believe in evidence-based practice. We believe in the scientific process. And this has led us to sort of understand psychedelics in a very particular way, which is that we do randomized clinical trials. We generate evidence of the effects of these substances on sort of the neuroplastic effects of the substances on our brain. We have a biological basis for understanding what they're doing, and that's how we approach them for the most part. Not entirely, but for the most part. In many Indigenous communities, that's like a whole nother language. Like, they think just differently than us. Like, their worldview is not based on rationality. It's based on relationality. It's based on spirituality and interconnectedness. They do not believe in time and space the same way that we believe in time and space, which is kind of really hard to get your mind around, right? They don't believe in time and space in the same way that we believe in time and space. They believe there are other realities that we can access that are happening at the same time as now, right? If we want to look at our time and space. And that the way that these substances work is when I've asked people in South America, like, how does this work? Their explanation is something to the effect of, it opens something in us. It takes us to another reality that tells us something about ourselves. That's like a totally different worldview. And so how we can kind of bring that together with what we're doing in Western medicine is really, really hard to reconcile. And I'm not sure we actually can reconcile it. It might be two separate things. But I think what we can do is we can approach what we're doing from a perspective of epistemic humility, right? So epistemic humility is this idea that we think we know what we know, but all of our knowledge is incomplete and could be wrong, because we don't actually know what we know, right? We think we know what we know. So if we approach it from that perspective, that suggests a whole different way of thinking about the ethics of this, right? It's this idea that, like, maybe, just maybe, there's like this tiny sliver that, like, they could be right, that we are going to another reality, right? We don't think we are, because we think we know what we know. They don't think we're right, because they think they know what they know. But maybe if we just leave like the tiniest space to acknowledge that we could be wrong, it could create a whole new way of approaching this that's a much less dogmatic, much more empathetic way that really emphasizes, instead of like individual autonomy and, you know, clinical benefit, it really emphasizes more respect and humility and compassion. And so I think that's sort of where we need to be going with our ethics in order to address this sort of gap between the two worldviews. Does that make sense?
Okay. Are there any questions? Right here in the front.
I'm David Holstein. I'm the psychedelic clinical trials program at the Psychedelic Institute here. A couple of questions. One is, I think the psychedelic drugs are very different than other treatments, as you pointed out. And one of the things, as Michael Pollan's book, in the title, How to Change Your Mind. And I think we're not really used to treatments that actually change who you are. And the fictional patient that you presented seemed very eager to change who she was. But I'm not sure that everybody wants to change who they are. And I think there is an ethical question in that area. And I'm curious what your thoughts are about that. If you came from a certain very conservative, say, religious framework, it might be very shocking to have your kid change.
Mm-hmm. Yeah, that's a great question. So in the bioethics literature and in the philosophy literature, there's been a big discussion around sort of like, is this sort of the classic idea of a transformative experience? And the idea of a transformative experience is that it changes what you know, and it also changes you personally, like who you are, like your value, your core values, your beliefs and things. And there's lots of debate about whether this is, in fact, we've done studies looking at, like, we've done some empirical qualitative work looking at, like, is the way that people describe these experiences really sort of a classic transformative experience. And what we have found is that it can change people. It doesn't always. It can change people in certain ways. It doesn't fundamentally change their sense of, for the most part, who they think they are, but it can change sort of how they process information. And I think that's why sort of the psychotherapy around the experience is so critical, because it can help people make meaning and make sense of their experience in the context of what they're comfortable with. I mean, you probably know more about this than I do, but in the context of like, it may disrupt what they grew up thinking a little bit, but it may fit very nicely in what they grew up thinking. And people, we may find that people who are, devout Christians can understand the experience in a way that's consistent with their belief system. And it doesn't have to completely change their belief system. I think that's possible. But for some people, it does sort of move them outside. And what I've heard anecdotally people say, a lot of people say, is it didn't change what I believe. It didn't change who I am, but it softened my approach to that. So it's this idea again of epistemic humility, right? It actually created some epistemic humility for them. It created the possibility that like what I believe and what I grew up in may not be the only way. And there may be a possibility of other ways out there. And what that opens up is the possibility that we can then be more tolerant of each other. And I will just say that I think in today's environment, we could all use being a little bit more tolerant of each other and kind of seeing those lines. So I don't know if you agree with that. I would love to have more of a conversation of what your experience has been as somebody who does these trials and what you've seen with the people who are participating. But that's been my sense.
Yeah, I think there's a lot of expectation, and some people are very disappointed to not be transformed. And I think others may feel disoriented or disconnected. And they may have said, well, I want my depression to be better, but I don't necessarily want to change who I am or how I perceive it. So I think it's very, I think it's something to study. That's
absolutely. And I think also one thing that you brought up, which I think is really important, right? You talked about like the parent who may not want their kid to change. This comes up a lot also with couples, right? So if, one member of the couple goes and does a psychedelic assisted experience or therapy, they may come back and approach the relationship quite differently. And so what's the obligation to sort of involve, is this a social treatment? Like, should you be involving sort of their network in setting expectations, in understanding what's happening and providing the support? Or is this really, can this be done in a really individualized way? My bias is that it's a more social. I think a lot of medicine is more social than we tend to acknowledge, but this would be one of those examples.
We actually are planning a study to treat both members of the couple.
Yeah.
There's a question over here and then one in the back, but then I'm going to ask one from the Zoom room. So Fernando Rodriguez is asking, are there guidelines for the psychotherapy that have been paired with the clinical trials?
So MAPS has they've put out their treatment manual, which is kind of their protocol that they use in the psychotherapy component. I think one of the challenges is that it's not very well defined. And one of the biggest debates in the field right now is what is the appropriate psychotherapy to pair with this? So they use something that they've called like inner-directed care, and or inner healing, and it's been, it's not sort of one of the evidence-based therapeutic modalities that are out there. And so people have argued that it would be better to use like cognitive behavioral therapy while you're doing this, but we don't have enough data on what works, and not just what works, but what works for what substance, for what condition, for what you're trying to treat, and what works best. So I think there's a lot of work to be done with regard to that.
Great. All right. So here.
Hi, great talk. Just wanted to ask what you think is the major difference between using psychedelics versus using established, drugs that go along with psychotherapy or might be prescribed by a psychiatrist. I mean, the argument that like a psychedelic will change your persona and make you approach your social engagements differently. You could say the same thing about antidepressants. Like those can also kind of change the dynamic of the relationship.
Yeah, I think that's right. I mean, that's sort of the goal of therapy, right? Is to try to change a little bit what you're doing and in positive ways. So yeah, I think that's absolutely true. So I mean, when you ask what the difference is, I'm not sure exactly what you're getting at, but I think one of the things that is promising about this is that it's not a lifelong treatment. It's not even like a long-term treatment. Like the studies that have been done are suggesting that you do, 1 to 3 sessions, and it can have at least somewhat lasting effects, and you're not on a drug every single day. So I think that's appealing to some people and might be a different paradigm than what we're used to thinking about, which has all kinds of implications for commercialization and all kinds of things. But I think that's somewhat different. But did you have a different, is that kind of what you were getting at, or?
Kind of. I mean, I think if there's like a one-time, like with the MDMA trial, or I guess with psilocybin, there's also maybe one-time psychotherapy experiences that will have a lasting effect. You might not need to be prescribed something, but I guess why is it so much harder to certify somebody to manage a psychotherapy session using psychedelics versus, say someone who's administering antipsychotics or antidepressants?
Yeah, I mean, I think it's the intensity of the session itself is part of it. You're in a altered state of consciousness, which is a little bit different than, that's different from when you're on for the most part, when you're on a antidepressant or something like that. You may be experiencing things that you not only have never experienced before, but you never had sort of the access to even know that that was something you could experience. So a lot of people talk about sort of the possibility, and this doesn't happen with every experience, but the possibility of having what's called a mystical experience, which is this immense feeling of awe and oneness and interconnectedness akin to sort of a very profound religious experience. Some people, there are some similarities in that. And people may not be expecting that. They may not know that. That's quite different from what they would experience in their daily life. They're in an altered state. And so managing that with a client or a patient could, I think, requires a potentially different skill set.
Thank you.
Yeah.
Back.
Okay, thank you so much for the talk. I was wondering, and you might have kind of answered this question, but right now, the way that drugs are used in hospitals specifically, they tend to be given, like, there's a lot of drugs given together, and also in spaces that might not be like the most conducive to this kind of experience. And it obviously seems like these trials that are going on right now are focusing on outpatient, one could say, experiences. I was wondering if you see a future for, in thinking about how these drugs can be used in the system that we already have set up for patients that are having a really hard time, for example, coming to terms with end of life and probably won't leave the hospital, things like that. How do you see fitting that into the framework that already exists?
Yeah, so you're getting at a really important point, which is in sort of the psychedelics field, we talk about the importance of set and setting, right? So set is sort of like the mindset that you come into the experience with, and setting is the physical environment that you're in. And it's really interesting because this, again, changes differences in worldview, right? I remember being in the jungle and asking sort of some folks who I was down there with who are part of an Indigenous community down there, and I said, what do you think about us using substances like this in the United States instead of studying it? And they're like, this would never work outside of the jungle. Like, the whole point of this is connecting with nature. How could you do this outside of nature? So, and that's not what we're doing. We're doing it in a clinic room. Sometimes there's limitations on what we can put in the room from regulatory perspectives, like you have to be able to wipe them down and things like that, right? So it is quite different, the setting. Most of the trials are being done like on an outpatient basis, which is interesting, right? Because you go and you do an intensive psilocybin experience and then you go home, and it's really important to make sure that the person you're going home with and the environment that you're going home to is conducive to what you just went through. You're still sort of in a vulnerable state and that sort of thing. There are some studies that are looking at like end of life care, and they're working with patients who are in hospice or palliative care. And so that might be, I don't know the details of their study, but I imagine that it's done more on an inpatient basis. So I think there's pros and cons to that. And I think you can do it that way. I will also point out that I think there are some in the field who are envisioning kind of a different type of medicine being practiced. So they're thinking about sort of like setting up a fully regulated integrative medicine type of clinic for these things that might look quite differently than what we're used to for traditional clinical care. And we'll see sort of how those models develop.
Okay, I have a question here. I'm gonna take one from the Zoom room. They're coming in fast and furious now. So, one question is about, and you're gonna have to draw on your law background, Amy, for this. I think there's questions about the ethical and I guess legal implications around R&D of synthetic psychedelic analogs and relative ease of IP acquisition versus natural psychedelics.
Yeah.
Yeah.
Okay, so I'm not an IP lawyer. I'm barely a lawyer. Probably jump in if you want to. But so I will say that yes, there's a distinction between, and this is true not just of IP, but it's true of sort of all of our regulatory stuff of like regulating a plant or a botanical, right, versus regulating a synthetic product is quite different. It's just easier to regulate a synthetic product because you can control better the consistency and what's in it and that sort of thing. It's also easier from an IP perspective to patent that. You know, if you're patenting psilocybin from a mushroom, it has to be a particular compound that you have figured out. You have to do something different. It can't be just from nature. And so there is that piece of it. I will also say that the whole marketplace is a whole nother conversation that I'm probably not the best person to talk about, but I find it fascinating, right? The whole sort of like drug development marketplace of this. There are people who are trying to develop synthetic compounds that get rid of the subjective experience of the psychedelic, right? So that you don't actually have the experience of, let's call it tripping, right? Of having that like altered consciousness, dissociation, or whatever it is that you're feeling. And you can still get the same sort of neuroplastic effects on the brain. So you can envision maybe if that is successful, and lots of debate about whether that would be successful or not. The idea there is that you could develop a drug that you actually would, like an antidepressant, take every day and have effects on the brain. We'll see how that develops, but that's a very different model than what we're used to. So I don't know if I'm answering the question specifically, but lots of IP implications of that. And I will say that there's a lot of people trying to get IP in this space and lots of debate about whether that should be allowed. And again, this issue of benefit sharing for the knowledge about these substances, even if they're synthetically derived, the sort of background of these substances from Indigenous communities.
Question over here.
Hi, thank you for your talk. I'm a graduate student and I had a question. My limited understanding is that, you know, two people could take ayahuasca and have, let's say, completely vastly different experiences. And my question is kind of probably, I don't think there's any maybe quantitative evidence, but just like anecdotally, what do you think, how do you think about the interaction of the medicine with someone's subconscious? And like the previous question asked earlier, if you don't want to change who you are, will you not change who you are because your mind wouldn't even go to a place that you were unwilling to go to? Or I guess, yeah, how do you think about the interaction of the drug with the subconscious?
Yeah. So again, I think the answer to that question would be very different for different worldviews, like how you explain the drug, right? So from a Western medicine perspective, like you're right, like we see different responses that people have. They have different experiences, they have different outcomes, they have different, and I think that would probably be explained through kind of our pathways in our brain and biologically. I can tell you from the perspective of the Indigenous people that I have worked with, because I've asked this question before, their answer, which is not going to make sense to many people in this room, is the medicine knows what you need when you need it. That it's not you that has any agency over what you need per se. The medicine knows what you need when you need it and what you can handle. That's again, very hard for people that are entrenched in our worldview to kind of buy into that or understand it even, but that's how they would explain it. But I don't know I mean, it's a really good question. I don't know if like you come in and say, I don't want to change who I am, I just want to get rid of these symptoms, whether either like your subconscious prevents you from making those changes, or I do think you have some agency over sort of how you interpret and how you make meaning of it. I don't think you have this experience and all of a sudden you have no agency over like what happens to you. I think we all kind of have, you know, if you do it, you have the experience. And then there's the work of like, okay, what does this mean for me in my life? And that's going to be embedded within sort of your own, where you are psychologically and where you'll be. And I'll also say, I mean, it's not just that individuals have different experiences. One person, when you do a substance, will have a vastly different experience this year versus next year versus 5 years ago, or even today versus tomorrow. Like it really depends on sort of a lot of different factors, but part of it I think is where you're at and how you're coming into the experience. I think that's part of it.
Okay, one more question from the Zoom room. Joy Chen thanks you for the insightful talk, and then says she's curious about the challenges patients might face if they wish to withdraw mid-therapy during psychedelic treatment, and if this would challenge the implementation of informed consent in healthcare practices for such therapies.
Yeah, that's a really great question. So I got really interested in this because I was doing some interviews and somebody was talking about this. So the challenge is, right, like you're in the middle of a psilocybin session and you decide, I want out, I want to go home, right? And there are, most of the clinical trial protocols have mechanisms in place to prevent that. And it's usually like making you stay until they can make sure that you're safe. And that is like blocking the door, taking your phone, those sorts of things. But I think it raises, I mean, for me, when I heard this, I was like, oh, that raises a really interesting question about how far do you go to restrain somebody? Do you like actually restrain them? Like, you know, but this has to be discussed during the consent process, and they have to understand that once you take the substance, we will not let you leave the premises. You can stop participating in the conversations or in the therapy or whatever's happening, but for your safety, we can't let you leave the premises until we feel like, you know, the experience is over and that it's safe to go home. So it does create that challenge, but and it has to be addressed in the consent process.
So maybe I'll take the opportunity. Are there other things that should be in the consent process that is unique to this?
Yeah. So the consent process is really important for this because we talk about the fact that, like, we were talking here about expectancy, right? And what, you know, when we say that set and setting are important, we mean that like your mindset going in can very much influence your experience that you have. And that means that like what you're told about this can actually influence the experience that you have. So we want to, you know, this is true always, like whenever you have a consent process, we frame things and that influences how people think, right? It creates implicit biases, it influences decisions people make, it influences how they think. I think it's heightened in this context where how you describe what they might go through might actually impact what they go through. And so you have to find in the consent process sort of that balance of giving them enough information to know what to expect so that they're not frightened, confused, things like that, but not overly influencing them. And then you raised a really good point about creating expectations and the fact that they may actually not experience anything, right? The last trip that I did down to South America, we had a group of people and they were participating in an ayahuasca ceremony. And there was a young girl who was like 24, 25. And the next morning we were all kind of processing what, you know, the group was processing what happened and she was hysterically crying. And so, you know, nobody kind of knew what was going on. And ultimately what it was is she was so disappointed because she didn't have this like amazing experience that she thought she was going to have. And she had sort of all of these expectations built up around it. And then she didn't have anything. Like she felt like she didn't have anything. I think she did have something, but she didn't have what she thought she was going to have. And it was really, really disappointing. And so we need to set that up too, to make sure that people really kind of understand the range of experiences that they could have and the range, you know, set their expectations appropriately so that they're not either disappointed or overly taken for surprise if they're not like expecting something that happens and it's really profound for them.
Okay. Are there any other questions in the room? One more.
Thank you so much for your speech. It's really informative. And I would like to ask, so can we see the psychedelic medicine as an alternative medicine at this point? And because there are many alternative medicines, even in other spaces or fields of medicine, even cancer treatments and all kinds of weight loss and you name it. So for the medical institution and like go to see a doctor and the doctor say, oh, what other drugs you're taking, and are you taking any herbal medicine or seeing any like alternative options? And for the psychedelic medicine, what do you think it's different from all the other alternative medicines, and what are the challenges might emerge or new challenges might emerge to be able to say like mutually coexistent or to manage them in a way that people can maybe switch from one or another or take both too and still get benefits from both of them.
Yeah, I mean, I guess it's an alternative medicine. I mean, it's used as a medicine in many places. That I guess if you define alternative medicine as medicines that are used outside of our regulated healthcare system, then I guess you could define this as an alternative medicine. You know, I think the main thing that you brought up that's really important is I believe there are a lot of people using these, and I suspect, although this is not evidence-based, that they're probably not talking to their physicians about it. And we've done a study actually looking at like thousands of people with OCD and whether they're from all the Latin America and North America, and whether they're using psychedelics to treat their OCD. And there are a substantial minority who are, or I think a substantial minority who are, like less than 10%, but close to 10% that are using psychedelic substances to treat their OCD, and most of them are being done outside of the healthcare system. Are they talking to their physicians about it? Are they, is it affecting their symptoms? I mean, this is something I think that, again, having some humility around this can open up those lines of communication and conversation that can be pretty critical to helping the patient in a more holistic way. So I would advocate for that.
All right, well, we have gone past the hour, so I'm going to close this out, although we do have the room until 1:30, and Amy's here for informal discussion, so please come up if you have further questions. I want to really thank Amy for coming out here to Columbia and giving such a fantastic presentation, and for your engagement with such great questions. We will be having our next ethics grand rounds starting in the spring semester on February 11th. So mark your calendars. This will be on medical assistance in dying, or MAID. And we will have a guest speaker, Yvette, thank you, Yvette Vera, who will be speaking on MAID. So please do join us then. And there are some surveys that we have handouts in the room, and then there's a QR code that will be dropped into the chat in the Zoom room for you all to fill out. We take this feedback very seriously, so please do fill it out. That would be a big help. All right, so if there's any food left, please grab it.